atlantodental interval disturbance, there is no real compression, and this kind of basilar invagination group 2 with Chiari and syringe, the whole world today will do foramen magnum decompression. But look at the facets. The facet of C1 is behind the facet of C2. There is an element of rotatory dislocation or translatory dislocation. This is clearly, definitely, and positively an unstable issue. Stabilization is the treatment. And in this situation of unstable spine, if you do any kind of decompression, in my estimation, there may be counter arguments and discussion and all those things, which I hope and I wish that you don't have. That this kind of unstable atlantoaxial joint needs stabilization. The other thing that we realized in very chronic situation, there are morphological changes. Like even when the facets are in alignment, even when there is no atlantodental interval disturbance, presence of assimilation of atlas, presence of Chiari, presence of C2-3 fusion, presence of platybasia are all indicators of unstable atlantoaxial joint, and stabilization is the treatment. That is my concept, and that is completely a firm concept with my experience now going over 550 cases. Assimilation of atlas, C2-3 fusion are all participants of chronic unstable atlantoaxial joint, and atlantoaxial stabilization is the treatment. Now you carefully see this slide, which is very few I have indicated here. Chronic atlantoaxial instability. There may be Chiari, there may be syringomalia, there may be basilar invagination, there is short neck, short head, short body, bifid C1, bifid C2, os odontoideum, torticollis, short neck, and a number of other problems. When Chiari is present alone or discretely, or Chiari is present with syringomalia, or syringomalia is present discretely or with Chiari, or basilar invagination is present alone or with Chiari and syringomalia, with C2-3 fusion, or C2-3 fusion is present alone without any other issue. Assimilation of atlas is present alone without any other issue. All these anomalies or alterations which I have listed, and many more, at least 50 more anomalies that we like to call as pathological. We like to call them problematic, and for which decompression is the treatment. I am saying that is negative thought. All these indicate chronic atlantoaxial instability, and for all these issues, atlantoaxial stabilization is the treatment. So now I want to show just one or two cases for this kind of fixed dislocation, hardly any space, transoral decompression. I was doing at least for 15 years this kind of case, and this was considered to be fixed problem. Decompression was the treatment, but there is a possibility of opening the joint, atlantoaxial joint, distraction of the facet, realignment, and craniovertebral realignment. Essentially, I have talked about all these things in my earlier lecture. I don't want to repeat it. I want to open the discussion at this point, and then I will show you more cases. Now, here is one case which I want to show you before you go further. This is a case of Chiari formation. There is no atlantodental interval disturbance. There is hardly any compression here, but you look at the facets which are clearly and definitely and positively unstable. Whether there is type 2 or type 3 or whatever, presence of Chiari is a clear indicator of atlantoaxial dislocation, and atlantoaxial stabilization is the treatment. And Chiari will reverse, syringomalia will reverse. Chiari reversal may not be there. Syringomalia, reduction in syringomalia, I showed last time several cases. I will show you again now. Syringomalia is secondary. Chiari is secondary. They are protective and adaptive, and they are reversible following atlantoaxial stabilization. One last case I'll show you. This is, of course, basilar invagination. Issue is facetal listhesis. Stabilization is the treatment. any kind of decompression is not such a great option. This is another case of basilar invagination. Whether there is basilar invagination or no, whether there is syringomyelia or no, whether Chiari is with C2-3 fusion or no, whether it is with Klippel file abnormality or no. There are several permutation and combination. All these issues are secondary to chronic. Now, the question that you might like to ask me is, why in some cases there is basilar invagination and no Chiari? Why in some cases there is shortening of the neck and torticollis? Why in some cases there is C1, C2, C1 assimilation? Why in some cases there is Klippel file abnormality? So the answer to that question is a little difficult to answer, but the pattern of unstable spine over the duration, the pattern of whether right side is affected, whether left side is affected, whether the both sides are affected, early affection, delayed affection. There are so many issues which can be questioned and which can be answered. And I want to show you just the last slide before I open this discussion with my colleagues in Brazil. This is case of Chiari with syrinx. You see Chiari with syrinx, there is assimilation of atlas. There is little bit facetal listhesis here. And I have done fixation. And I can only tell you one thing, which you must, as I mentioned last time in August, I am conducting one live surgical show on craniovertebral junction with symposium where I am inviting various people all over the world, including Ricardo. My invitation to you will come soon. And of course, to other people in the audience. And I wish that you come and you see. And, when I talk, you should not completely, after all of you are senior people, when somebody talks may not be the right thing, but I want you to come and see in August, and my invitation will be there. And I have already told last time that for all the Brazilian people who will like to come, my registration fees for the meeting will be completely free. And I will also see if I can give some accommodation to a group of people from Brazil. So this is my commitment, and I wish. So I open it, Marcos, for discussion, and you please let us see how we can go further. So I will stop for the time being.
Thank you, Professor, for these great explanations. Please, Ricardo, can you add something other Brazilian friends can sequentially speak about the impressions and opinions about this? Thank you.
Well, thank you for this invitation. Can I share some slides?
Yes, feel free, please.
Probably Dr. Go is right in the almost all parts that he is talking about. But there are some points of view that we would like to discuss. I will try to share my screen. Okay. Can you see this screen?
Yeah, perfect.
Is that okay? My name is Ricardo Botelho from Brazil. Dr. Go is my friend from a large time, and we have been together in several discussions, and he knows we have some points of discordance. I wrote while Dr. Go was talking. He stated that compression is not primary. We really think that compression is primary. He thought that instability is primary, facets are the problem. We consider that atlantoaxial assimilation is the primary problem, not the facet. Facets are the secondary problem. Probably we are looking different ways, probably to the same phenomenon. Chiari malformation is based on bone malformation. The clivus is short. The exo-occipital is short. And this, for me, is a primary problem. Herniation is a secondary problem. and facet listages are secondary stabilities. And Goel told that platybasia, brachycephaly, atlas assimilation are secondary. Well, this is one of his slides. What we can see here is a patient with atlas assimilation. We have here an anterior atlanto-occipital assimilation and a posterior atlanto-occipital assimilation. This is quite common in all type 1 that Dr. Gold brilliant described basilar invagination. And the realignment is the treatment. I agree 100%. He is right. He was, for me, the first to state this situation. And he is called here as a king. And in fact, in this situation, he is a king. Okay. There's another slide from Dr. Goels. He described as a Chiari malformation. But for me, this is not a Chiari malformation. I can't see clearly an anterior atlanto-occipital assimilation. This case is very similar to the anterior case. The difference is the magnitude of the dislocation and should be treated in the same way with atlantoaxial fixation. This is not a Chiari. Take a look. This is a type 1 basilar invagination. We need to make a clear division between all this kind of disease. This is a paper from 2012 that we share. We split the case into normal. You can see the head related to the spine. At the right side, we have a Chiari malformation that is very close to normal, very close. The only difference is that the occipital is short. This is the until now, until Dr. Goels, all the literature stated that the primary problem is a short occipital bone. And that's the reason that this disease is called Chiari malformation. The bone is malformed, is underdeveloped. In the lower part at left, we have the atlantoaxial assimilation that, for me, is the cause of type 1 basilar invagination, anterior and posterior. And the last is a disease very frequent here in Brazil, in northeast part. Dr. Wagner knows that we have a lot of this disease that does not have a primary instability, but they have short occipital, short clivus. And now we studied the sphenoid bone of these patients. Compare this sphenoid bone with those from type 1 basilar. Take a look at the difference. Take a look at the Chiari malformation sphenoid bone and the normal. One primary problem in type 2 basilar invagination is the sphenoid bone, but not only. There is a global underdevelopment of the bone. They have several other problems. This is a kind of disease that is named in India and in some parts of China, in some parts of India, as atlantoaxial dislocation. Is what I conclude that Dr. Goels described initially as type 1 basilar invagination. This is a real instability. And take a look what this is the common problem, is atlantoaxial assimilation. When we look at the whole literature, we can see the unstable case have a big prevalence in China and India and don't have the same prevalence in the other parts of the world. We know from South America that in Peru, they have a big incidence and prevalence of atlantoaxial assimilation, and a lot of these cases. This is a localized problem in some parts of the world. When we look at the platybasia, it's a primary and important disease. The base of the cranial is at the beginning, at early parts of the life, their cranium are flattened. This is a primary problem, not a secondary problem. That leads to craniocervical junction kyphosis. And take a look at this case. This is a complex. This patient had platybasia and atlantoaxial assimilation and instability. Altogether, all these bone malformations are part of the primary problem, that is a bone problem, and cause some secondary alterations. Dr. Go wrote 20 years ago that cervical hyperlordosis is secondary to atlantoaxial instability. This is right. But we have craniocervical kyphosis. The skull bends towards the atlas. Take a look at these cases. The relation of the skull to the odontoid process, take a look at the atlas assimilate, are almost 90 degrees. I would like to see case of Dr. Gold with this amount of craniocervical flexion treated by atlantoaxial fixation. The angle is very flexible. I don't have the ability to reduce this by atlantoaxial fixation. And brachycephaly, in one study very interesting from Nascimento, from northeast part of Brazil, showed that the more brachycephalic skull of the patients, the more invaginated are the patients. When we look at the shape of the skull in patients with type 2 basilar invaginations, the shape is round. This is the shape at right, the normal skull. At the left side, the shape of the basilar invagination. Look at the shape of the skull. This is a brachycephaly, and for us is a primary problem. And the last thing I would like to bring your attention, this is a paper from 2 or 3 months ago, the roloid sphenoid bone. Take a look of this sphenoid bone. The head is flattened, and the sphenoid bone is one of the cases. Ben, this is some points that I would like to bring to discussion with Dr. Goels. The ways of treatment, all these we can discuss. Well, I will stop here and put into discussion. Thanks for the opportunity to discuss. It's good to see all of you. I will stop my presentation.
Yes, Ricardo, that was a wonderful presentation. See, what essentially, as you know, I have been dealing with this craniovertebral junction for last 40 years of my life. And we have been discussing with each other, and we have written about it. You have written, I have written, several other people have written. But for the last 15 or 20 years, since I have written about Chiari malformation, about the issue of central atlantoaxial instability, my whole version, my life in craniovertebral junction has changed. When I wrote this article in about 15 years ago on Chiari malformation, there were several people in the world, in the world, who said that this may be in basilar invagination, it may be unstable, but not in normal bone. It is stable in the normal when the craniovertebral junction is normal. It is not possible in pediatric Chiari is different, adult Chiari is different. And there were several questions, and the literature is, it is all in the literature in Journal of Neurosurgery. Then I wrote an article where last time I presented some cases. I hope you can see my last presentation where I showed several cases where the craniovertebral junction bones were normal, but there was Chiari, and I treated by atlantoaxial fixation. So what I will do now is let me show you some more cases before we ask the next person to come into picture. So this is the case. Here you see there is assimilation of atlas, and this is actually a, the posterior part is bifid here, which is I'm not able to show you in this. There is some unstable spine, and I treated by atlantoaxial. Now, you know what? In my series now, which it is more than 550 or more, nearing 600 cases now, where I have treated whether basilar or not basilar, whether child or adult, whether with platybasia or not. All these cases I have treated by atlantoaxial stabilization. And as you rightly said, to do atlantoaxial fixation in case of basilar invagination group 2, in a case like this where the clivus is flat, there are several cases I will show you. Let me see if I have here today. I have shown last time with severe, the case you showed with severe basilar invagination. It is, in my estimation now, is absolutely clear that severe basilar invagination is due to long-standing atlantoaxial instability, and this is bone malformation, is not malformation, it is formation. Let me show you some more cases. Now, this is the patient who is 48-year-old lady, comes in. See, many of these patients will come with tingling in hand, paresthesia in fingers, pain in the neck. Pain in the neck will be constant. In all Chiari malformation, you see, when you see your next patient, you ask him or her whether there is neck pain or not. Neck pain will be a constant feature, and this is related to an unstable atlantoaxial joint. Second thing is they will say there is some tingling in the hand. Then as the thing progresses, there will be weakness in the legs. There will be spasticity in the legs. Then there will be voice change. The voice will become slow because the breathing becomes less. There will be sleep apneas. So when you do atlantoaxial fixation, in the evening of operation, the person will say, my voice has improved. Evening of the operation, the person will say, I can sleep better now. My sleeping pattern has improved and my tingling has gone. So there will be a magic kind of treatment. The problem is one. And to do atlantoaxial fixation when there is severe basilar invagination, even in this case, where the clivus is flat, to do C1, C2 fixation is not easy. I don't believe in occipital fixation now. You know that occipital screws were described by me in 1988. But now I am saying occipital fixation. It is all the game of atlantoaxial joint, and atlantoaxial instability is the issue. Whether it is a child, whether it is an adult, whether there are bone malformations or not, whether there are torticollis or not, and all those things. Let me show you some more cases where I call this central instability. So this case, there is no facetal malalignment, and I have done atlantoaxial fixation, as you can see, and the syringe is gone. There is no change here, as there was no problem earlier. And I have to only tell you, and you have to believe me. Either you say I don't believe you, but if you are not believing, I have given you an open invitation to come in the August meeting where I will show you at least 3 or 4 cases of Chiari malformation or more. You do fixation and you create a magic. The problem is to do C1, C2 fixation. People in Brazil are masters of doing. People in China have learned a lot about craniovertebral junction stabilization. And there are several groups in China who are doing this. Several groups in India who are now doing C1, C2 fixation for Chiari. You will see several spurts of papers coming up. For group A basilar, for group B basilar invagination. So this is fixation, and this is the torticollis. When you see a torticollis like this, severe torticollis, whether it is child or whether it is adult, you should suspect C1, C2 instability. You do C1. It is not an easy operation. A person who has torticollis and short neck, I showed last time several images. If there is torticollis and short neck, but the person is walking around, to do C1, C2 fixation is not easy. We know it. But if you do C1, C2 fixation, you can make the neck straight. This is immediate post-op within 1 or 2 weeks after surgery. And you see the torticollis is remarkably reduced. And I've got several children like this now. The issue is to learn the art of opening the joint, learn the art of C1, C2 fixation, and you can give new life to these patients. This is another child with severe torticollis, almost right angle. You see, right angle. The problem is there is no problem here. There is hardly any issue here, but there are facetal malalignment. The problem is whether you can do fixation, whether you know there will be serious problems during operation. There are some bone malformation here. If you see this, there is bone abnormality, which is natural, which is protective. It is like I have written in one article that it is like a cycle stand. We call it homovertebral. I will show you one image. These are also secondary, controlling the head like this from the side. You do fixation and you see this neck has become long and neck has become straight. Excuse me. And the only thing is craniovertebral junction is a difficult operation. Craniovertebral junction surgery is a dangerous operation. Craniovertebral junction, whilst you can give new life to the patient, you can kill the person. You can create disaster. You can create vertebral artery injury. You can have serious bleeding in these cases. So it is a difficult operation. Question is whether you can do it or not. This is another patient having only issue of neck pain. There is no problem here. What is the problem here? There is no problem in the craniovertebral junction. Facet is slightly malformed in this case, but there are several cases there is no facetal malalignment. But this is a clear, absolutely clear indication for me that we should do C1, C2 fixation. This is preoperative. This is very soon after surgery. And you see, I have done C1, C2 fixation. This is a complete revolution, Ricardo. Believe me, this understanding is different from what the entire literature is saying. What my professor used to say, my teacher who is a philosopher, that bone malformation, that bone is a servant of soft tissues. Formation will be dictated by what the soft tissues tell you. Bone malformation is not primary. This is my boss, my philosopher friend used to tell me. Like vertebral body comes secondary, disc comes first. Disc is primary, body comes later. So I like to call it interdiscal body, not intervertebral disc. You see this, I do C1, C2 fixation. I show you magic of radiology. This is another patient having just neck pain. You see this. You see, I'm not sure about sphenoid sinus. I promise that I will study in my next cases about sphenoid sinus. There is Chiari and there is syrinx having spastic quadriparesis. I'm sure the whole world will do foramen magnum decompression, dural decompression. The concept of tight posterior fossa, Ricardo, was introduced by me in 1998, where I said that the posterior fossa volume is small and you need to do decompression. This concept in 1998, where I divided basilar invagination into 2 groups, A and B, this concept was introduced by me. And now you see, there is no problem here. There is no problem here. What you will do, you think about. You tell me what you will do. The whole world will do foramen magnum decompression, and some people will do syringostomy in this case. I think if you do syringostomy, this is completely a negative operation. I think if you do foramen magnum decompression for this, is a completely not necessary. You do C1, C2 fixation, you see the syrinx going like this completely. Syrinx normally does not go completely, it reduces. It will not go completely, but it will reduce in 100%. When I say 100%, it is even difficult for anyone to say 100%. Means if there is somebody if one patient comes, you were saying 100%. If I say 95%, I may be safer. But I have no question. I'm saying 100%. You show me all my cases are in the field and they are, they can be identified. This is another case, Ricardo. Now you see this case. See, I'm not sure of this assimilation of atlas, the kind you were saying. There is some facetal malalignment. You see this syringomyelia, you see this Chiari, and you see this postoperative after 3 months of surgery. I have got reduction in syringe after 2 days of surgery. So there is no question in my mind. Of course, this topic will have to be studied by my friends in Brazil, where this population. Other thing which I am telling you, Ricardo, you said about India and other countries where instability has been the issue. And in other papers, instability has not been the issue. This question was raised in one of my articles where they said that Indian patients may be different. I am saying, Ricardo, this issue has been studied in chimpanzees. This issue has been studied in China by various groups. To say that American patients are different and Indian patients are different, Brazilian patients are different and Chinese patients are different, human being will not be different anywhere in the world. Human being will remain human being. Even chimpanzees, there have been recent articles, even in chimpanzees, Chiari malformation, there have been some groups who have done C1, C2 fixation. So don't say that Indian patients are different and patients in the other population are different. So C1, C2 fixation, and you see the magic of the clinical result. This is another patient. Syringomyelia, you see here there is bifid. No, here this patient has been treated by foramen magnum decompression. You see, patient has undergone foramen magnum decompression. He has worsened. Now I will tell you another thing. If you ask me what is your very common operation that I am doing nowadays, I am doing patients where foramen magnum decompression has failed and patients are coming after failure of foramen magnum decompression from all over the world, including from America. Tomorrow, I am operating one patient who is from another country where foramen magnum decompression has failed. So this has become a common operation for me now, where there is no problem here, no problem here. You do foramen magnum decompression has failed, and he has come to me now, and I have done fixation, and you see the syringomyelia has, and you have to I don't know how to show because my patients will not, I have not brought the videos of preoperative and postoperative situation, but you believe me, magic and complete magic is the clinical result. So what I will do is, I have several more patients to show you, but I will wait here and let us see if there is some counter question by Ricardo or by others. Let me wait for.
Okay, let's invite Andre to talk about it. Andre?
Can you hear me?
Yes,
I can hear you.
Okay. Thank you very much for this invitation. It's an honor to be here to learn with Professor Goa, Professor Botelho. The experience of Professor Goa is unquestionable and undeniable. I think today I fix more patients that I would not fix in the past. I understand basilar invagination better because of him. But treating these patients, I have some questions to you that, for example, well, many situations we do a decompressions and the patients do really well. For example, in 90% of Chiari patients, pediatric patients, children get better and you don't have to put the screws, you don't have to have the atlas fixed. In Brazil, most of my patients, when I discuss about to fix the C1, C2 joints and they lost the mobility of the joints, they go out and search it for another doctor. People are afraid of screws. And what I want to ask you, if I have some patients that I can treat without fixation, despite I understand that most of them, you show the case. It's not, I cannot argue against you because you show the results. You show the screws, the patients, the MRI, and the patients, okay, you solve the malformation, but they have a C1, C2 fixation. They cannot rotate their neck. And it's you. I have some experience with C1, C2 fixation. It's not easy. It's not for, even for spine surgeons, basilar invaginations, the condyles are pretty high and it's difficult and dangerous. The point I want to argue you is that if some patients can benefit of decompression without screws and allowing them to have the preserved rotation of atlas, it doesn't worthwhile try to be like a sniper and to avoid to fix everywhere. Because when we talk about your work here in Brazil, what some good surgeons question me is that, oh, if we do this for everyone, for all the patients, maybe we can treat some of them without C1, C2 fixation. That's the question I'm asking you. Can we spare some patients of have atlantoaxial fixation?
Okay, Andre, that was a very good question. And Andre, you know that we have discussed various issues about various problems in the past. And this question has been asked to me by several people. Whenever I give lecture, many people ask me this question, that my patient has improved after foramen magnum decompression. So why we need C1, C2 in all these cases, particularly in children? Now, let me answer that question, Andre, and I'm talking with greatest honesty, which I can show my honesty to you and to the world. I have given several lectures. I have to tell you one thing, that this concept of tight posterior fossa, which I have talked about myself, first time I introduced the concept of tight on the basis of morphometric examination, that foramen magnum posterior fossa is tight and you do foramen magnum decompression. I said that you don't need to open the dura, that because it is a bone problem. This is what I had said 1998. And I have been doing foramen magnum decompressions for a long time because I have introduced this concept. Now for 15 or 20 years, I am doing C1, C2 fixation for all these cases. In pediatric patients, the recovery is much more remarkable, outstanding, absolute magic. Like, for instance, a child, and I have written paper on pediatric, you please read my articles on pediatrics. And now I have got several, maybe in hundreds, not hundreds, but 100, nearing 100, less than 15 years pediatric population, which I will produce my next article on pediatric population. Now, you see, you ask people who are able to do good fixation.
Você tá com fome, né?
There is some
Tá
noise.
com fome, tá comendo uma pão cru.
John, just get this. There is some noise, John.
It's okay, Professor. Continue, please.
Let me stop sharing. Yes. So you can hear me, Marcos?
Perfect.
Okay. So the answer to the question of Andre is, you see, foramen magnum decompression, when we do foramen magnum decompression, we tighten. Now, to answer your question, why the patients improve? To answer that is, when you do foramen magnum decompression, after that you do muscle stitching and there is severe pain and in the neck and all those things, and the person will improve for a period of 2 months or 3 months or 4 months, but then there will be sudden slightly and then there will be decline. This is my feeling. As far as the movement, rotation, John, just see this. as far as the rotation movement loss is concerned, if you see all your patients, Andre, can you hear me, Andre? Yeah. Yeah. If you see all your patients of Chiari, there will be severe neck pain, or not severe, but quite significant neck pain in these patients. They will, if you touch the muscles of the neck in all, you see in your next patients when he comes, you touch the muscles of the neck, there will be spasm of the neck muscles. You see that in your next patient.
Yeah, I agree with you, Professor, but
Just let me complete, Andre, and I want to hear from you. If you see your next patient of Chiari, there will be neck spasm and neck muscle and neck pain, which are, in my view, clear indicators of unstable spine. And when you do your C1, C2 fixation, there is certainly some loss of movement of the neck, but these movements may even be better than the movements before operation in these patients because they are not moving the necks properly in Chiari malformation. The other thing is, as you rightly said, to do C1, C2 fixation is not an easy operation. If you ask people who are masters of C1, C2 fixation, and if you ask people who have never done C1, C2 fixation, they will never agree to this concept because they don't know how to do C1, C2 fixation. So my recommendation is, I'm absolutely convinced in what I'm saying. You do foramen magnum decompression in an unstable C1, C2 joint, there might be improvement for 2, 3, 4 months because you have stabilized, there is neck pain and all those things. But after 2, 3, 4 months, the decline will start and it will progress. This is my answer to your question. Andre, will you please say what you have to say?
We have some patients that I agree with you about the neck pain, some patients, but when we discuss about, okay, let's come back and have a fusion, they refuse because they said, oh, I can live with this neck pain. Maybe because in Brazil, people are afraid to have a fusion. I don't know why. You made a parallel of C1, C2 with the L5S1. I love it, the comparison. And it's the same, for me, it's the same because some patients with L5S1, we treat it one way, and some patients we treat the other way. That's why I agree with you. Of course, I trust in you, but I think that maybe there is some cases that we can not fuse them. That's my point. I understand you that most of them is still with neck pain, and probably because you have the detachment of the most of the muscles. But maybe some cases.
You know what, Andre? I want you, because you are one person I know for a long time, whose mind is thinking. You are one person who is thinking, and you think and you argue and you discuss. And you are a kind of a scientist. You are having a scientific mind. We are all scientific-minded people in neurosurgery. We should learn the science and art of neurosurgery. There is no question. I give you a special invitation. I give you special invitation to come and spend 2 or 3 weeks with me. That is one thing. That is one. And I have to also tell you that I have got fellows from all over the world all the time. And there are people who are my sternest opponents. They argue with me and they fight with me. Some pediatric neurosurgeon who said, no, I cannot agree. Pediatric population is different and I don't agree and I don't agree. And you are, whatever you are saying is your personal belief and all those. I called him in my department. For 3 weeks, he was with me, one of the leading pediatric neurosurgeons. He was with me for 3 weeks. And now I will introduce to you when you come here. I don't want to take any name, but he is now my most strongest proponent of what I'm saying. So I invite you personally. You come. You are a scientist. You cannot just, hypothetical, no, I don't agree, I agree. And I say you agree, you say I don't agree. Why don't you come? And I'm giving you a personal, you stay in my house, I will keep a room for you. And
thank you very much. We're we're gonna plan something like that. Thank you for the
Professor,
invitation. It would be a great honor.
excuse me. So it's a dynamic instability, as you say, because most of the exams that we do is in a position, the patient is not moving, so we cannot see what is in the real world, what is happening.
That's right. That's right. So there are no fixed parameters, radiological parameters. I described 3 types of atlantoaxial instability on the basis of facetal malalignment, type 1, type 2, type 3. And now I'm studying this more elaborately and including various other parameters in the discussion. And you will see some more papers from me coming very soon on the radiological assessment of these patients. And, as you can see from the way I'm speaking, the way I'm talking, and I'm absolutely convinced about what I'm talking. So what, Marcos, I'll do is some more cases I'll show so that by the time others...
Let me invite some other friends to talk, like Marcelo Mudo, Fábio Santana, Modesto, Luis Fernando, other friends from Brazil who want to talk.
Can I make some questions for Dr. Goel?
Sure,
Yes.
Go ahead.
Dr. Goel, Marcos, can you share my screen?
Yeah.
Okay,
Yeah.
thank you.
Are you going to share your screen? We don't see it yet.
Not yet.
Okay, now.
Yeah, looks like you're not sharing your screen at all.
I want to see what kind of complications Professor Goel has and what reoperation does he does. I want afterwards you can talk about that.
So, Dr. Goel, excellent lecture, Ricardo, Andre, Dr. Goel. I have 2 questions to Dr. Goel. I performed your technique in Belo Horizonte in 23 cases, almost in basilar invagination. My first question is, in your book, also, you put some, when you open the joint, you put some cages or spaces in C1, C2 joints. And the last paper, you talk about not use spacer but bone. Or what do you do now? Do you use some spacer, C1, C2, or only bone, or only the screw and craft around the screws? Thank you.
That is very, very important question. Very important question. You see, I started off introducing intra-articular spacers in about 25 years ago. Intra-articular spacers, I used it for basilar invagination. I used it for atlantoaxial fixation. I used it for irreducible dislocation. I used it for rheumatoid arthritis. I used it for trauma cases, intra-articular cases. But my answer to your question now is that I don't use intra-articular cages. Very rarely, if at all, I use, very rarely. My belief is that open the joint, open the C1, C2 joint, which is difficult. In basilar invagination is not easy. It's difficult. Open the joint, introduce bone graft from iliac crest, small chips in the bone, in the joint, small chips, multiple small chips, and then do C1, C2 fixation, instrumentation. My feeling is basilar invagination with Chiari or with syringomelia or with platybasia or with torticollis or with any other problem. Atlantoaxial instability is the problem, and solid stabilization is the issue, and arthrodesis or bone fusion is the outcome. And if you put articular cages, the place for bone fusion becomes little less. So I introduce lot of bone graft in the joint, as much as sometimes it is not easy to introduce bone graft in the articulation. but small thin chips of bone graft I put in the articulation and then do fixation. I have a feeling that if you do not introduce bone graft in the joint and you do only metal fixation, it is not such. The best thing is there are 3 steps in my operation. Open the joint, introduce bone graft in the joint, and then do C1, C2 fixation. Then cut all the muscles attached to C2 spinous process very widely. You cut all the muscles because muscles will pull the joint. When if you do not cut the muscles around the C2 spinous process, these muscles are so strong that they will move the implant. So cut all the muscles of the C2 spinous process, drill, decorticate the bone of the lamina of C2 and arch of atlas, and put significant amount of bone graft behind. So bone fusion should be the aim. If you have cut all the muscles and if you have put the bone graft, it will be a solid fixation. That is the technique which I use.
Okay, thank you, Dr. Go.
Marcelo Mudo, feel free to join us. No.
Professor,
Luis? Ah,
thanks a lot for the invitation also. And I agree in some cases with you, but we are Brazilian, we are in a group and we are studying for a long time the craniovertebral junction. And I think that when you have only a hammer, all of is screws and nails. So I agree with Andre. Some cases it's not necessary to fix, but in fact, thinking about thinking everybody, I ask you, what do you do when the patient doesn't well after fixation? What are strategy for the unsolved case or for the patients who doesn't well after the fixation?
So that is another question you see when we are doing neurosurgery.
talk to us about your complications, Professor, that you have.
Yes.
Not complication, before the complication, but only patients who, when we have infections, when we have silver cirrhosis, there are complications. But sometimes the patient doesn't went well. This is my question, not about complications, because you operate on the patient and he's not satisfied with the results, for instance.
Okay, now let me answer this question very nicely and I will try my best. I will try my best to answer. I will tell you, for Chiari malformation, if you do foramen magnum, I was doing as I mentioned, you do foramen magnum decompression, none of my patients will be completely happy and satisfied. Nobody will be happy and they will continue to have some problem, tingling here, pain here, weakness here. Not one patient will be completely happy. And if you have heard me last time, several times in my lecture, I used the term magic, that I create a magic. And I also mentioned in my last presentation, and I also want Marcos to invite all Brazilian participants to come for my next lecture where I'm talking of degenerative spine, I'm talking of lumbar canal stenosis, I'm talking of lumbar disc. I want to invite you now. Now the question is about, when I talk about Chiari and treatment, I have got more than 550 audio-visual sessions with the patient where I ask them, how is the tingling in your fingers? How is the weakness in your hand? How is the power in your legs? How is your breathing? How is your voice? My last question is, have you got a new life? And I have got beautiful answers in several hundred patients, several hundred. I'm not talking of 5 patients or 3 patients or 4. Now you ask me a question, what kind of complications you can have in these patients? And this is a very relevant question. One is, I have said that I am doing C1, C2 fixation for 35 or 40 years of my life now. And this area, I am very conversant, I am very familiar. But I must say that even when I do today, C1, C2 fixation in a case of basilar invagination, I'm troubled. It is not easy for me after doing nearly 3,800 cases of C1, C2 fixation. I am saying today it is not very easy. Oh, it is very easy operation. It is not easy even today after 40 years of doing C1, C2 fixation. There can be danger with vertebral artery. I have injured vertebral artery on several occasions, and there are many articles of mine where I have said how to control vertebral artery bleeding, how to handle vertebral artery situation. I have got situation where I could not expose C1, and I had several difficulties in exposing. I have designed my own techniques of doing C1 fixation. If there is high vertebral artery, I have described the technique of mobilization of the vertebral artery. I have used inferior facetal screws and various permutation and combination. In some cases where I'm not able to do C2 fixation, I have introduced intra-articular implants for fixation. So it is a difficult operation, and you can have various complications or problems during operation. No, but if it is difficult, if it is dangerous, it does not mean it is a negative, it should not be done. Second thing is what complications you can have. You please read my article on this subject. The complications in my series are very, very less, but they are there. Not that they are not there. And there are complications is like some patients you can have persistent issues. You please read my article on Chiari, which is my last publication on Chiari a few years ago, where I talk about 393 patients where there were hardly any complications. And this is a real issue. The central atlantoaxial instability, which I am talking now, is absolute. There can be discussion, there can be argument, there can be counter argument, but this is the future in my estimation. I am not saying what I say is absolute and last word, and there will be many opinions and many discussions and many opinions. People are free to do whatever. But when I am giving a lecture, I give my thought. And my thought is understanding C1, C2 instability, particularly central instability, is a complete revolution in craniovertebral junction surgery. And if you are doing it properly, the chances of complications are very far and few, but they are there in every neurosurgical or spinal surgical operation.
Okay, thank
I
you.
didn't ask you about the complications, but what do you do with the patient? It doesn't go well. This is my question. I read all of your articles. I agree 90% with your theory, but I'm thinking with my patients. If I operate them, what more can I offer for them after if it doesn't works like magic in your hands, for instance?
Now, to answer that question, many people, when I give this kind of lecture, they say that why don't you do foramen magnum decompression at the same time? When you are there, why don't you do foramen magnum decompression also? I say it is not necessary. Now, many patients who have already undergone foramen magnum decompressions and they are not happy, I can say I will do C1, C2 fixation. I can answer that question. But if you have done C1, C2 fixation, I will not go and do foramen magnum decompression, that is for sure. The second thing is, if they have not really improved, there may be this issue that my implant has not been satisfactorily fixed, or if my implant has failed. That may be one issue. It has never happened. I've never reoperated my spine. But that can be one issue, that if you are not able to do introduce bone in the joint, your implant has not stabilized, and arthrodesis has not resulted, and you might have to reoperate. That may be one issue. Second issue is sometimes it is a real issue. Like you have done C1, C2 fixation. There is subaxial degeneration, like C3,
Yes.
4, C5, C5, C6. And when you do, you don't have to touch C2, 3 subaxial. But if the patient has not improved, I have done in at least 2 or 3 cases where I have gone and done subaxial treatment, subaxial stabilization. And I'm going to present this in my next presentation next week. I invite you for that. But to answer your question is what you will do is a difficult question, because I have not had too many patients who have been unsatisfied, but I have done subaxial fixation. I have never reoperated and done foramen magnum decompression. I have got several patients from all over the world where foramen magnum decompression has failed and I have done fixation. And so that is the answer to your question.
Thank you.
Thank you, Professor. I think we can stop for now. It's almost 1 p.m. in Brazil. So, Ricardo Botelho, can you give the final impressions about this chapter today? And Professor Goel has invited us to next week to talk about his philosophy on degenerative disease from the lumbar or all over the spine. Ricardo, please.
Always is a big chance to see AtuL again, to discuss and to fight against AtuL. I suppose as I was not able to fight against AtuL, and I didn't do it. It's a pleasure. Marcos, thanks for having all this environment for discussion. Brilliant talks. Thanks for all.
Yeah, okay.
Good to have all of you.
So next time, invite our friends and let's be together. So what's the topic, Professor, next time? Can you tell us?
Next
What you
topic,
think?
I will be talking on degenerative spine. I will be talking on cervical spondylosis, lumbar canal stenosis, lumbar disc herniation, Hirayama disease, OPLL. So I want to give a different version of spine surgery next time. And I invite all of you to listen to some different kind of concepts. Ricardo, please come. Andre, please come. And we will enjoy discussion again.
Okay, see you next time, Professor.
Yeah, it's
Thank
always good.
everybody. Thank everybody. Yes.
Yeah, the king, it's always good to see the king hold his court.
Thank you.
Now,
Thank you.
this
Thank you, Marco,
chapter he
for
became.
radiating.
Are you
Bye-bye.
happy, Professor? No, not too much. Fire it.